you. I am here. Good to be here.
Good morning, Senator Lyons. I am getting used to needing to look at my colleagues in person and then remembering to look at screens and sorting all of this. And so maybe a wee bit bumpy, but let's begin the meeting of the HROC. It is a little after 4 on August 4th.
It's a little after 4.
It is August 4th, and it's a little after 9. Senator Lyons is joining us remotely. Senator Rick Westman was not able to attend today, but otherwise the rest of us are here in person. And our first presenter, thanks to the good work of Senator Kitchell, we're hearing from Donna Kinzer, who is with DK Healthcare Consulting. The question, I think the purpose of our being together this summer is to kind of interrogate the revenue and the financial, not the revenue, the financial aspects of our healthcare system, and to understand if we're making appropriate choices in the policy decisions we're making with regard to revenue, the cost of the system. I don't know why I keep saying revenue, forgive me. Senator Kitchell, through her vast array of connections, had some excellent ideas about folks who could help us understand that. And so Senator Kitchell, and then we'll...
Well, good morning. First of all, I'd like to welcome Donna Kinzer and also Rachel Block, who is with us. Rachel works for the Milbank Foundation, and it's with the involvement of Milbank that we have Donna here today. She was recommended to us as someone who has a great deal of experience in terms of the healthcare costs, and was at one point in her career, I believe, head of Maryland's Cost Control Commission. I probably got the title wrong. Sorry, Donna. So I just want to recognize the role that we have with Milbank in making this resource available in terms of their own staff, Rachel, and a national consultant, Donna, and whose background is really in fiscal area of healthcare. And so we thought that it would be helpful to have the benefit of some experience of other states, but Maryland has certainly been one that we're aware of in terms of their cost control efforts and healthcare regulation. And so we are here partly because obviously there's been a lot of articles in the paper, et cetera, and the question really is, what kinds of questions should we be asking? What kind of information? Are there statutory changes that might flow? But first of all, understanding what is driving costs in Vermont, what is sort of the current regulatory scope of the Green Mountain Care Board, whether that is, the current structure, whether it needs to be modified, or are there other ways that other areas in the country have implemented effective cost control strategies, and whether improvements can be made here in Vermont. So that's kind of the framework that we asked. We accepted Milbank's help, and want to welcome Donna to our committee this morning. So thank you.
Thank you for setting that up so nicely. And let me just interrupt before we turn it over to Don. I wanted just to acknowledge that Kevin Mullen with the Green Mountain Care Board, who's joining us during a presentation at 10, is also with us. So thank you for being here early to listen to this presentation. So to you, Ms. Kinzer.
Madam Chair and committee members, thank you very much for the opportunity and the honor of being with you here this morning to discuss the important matters that you're looking forward to in terms of moving the payment and delivery systems in the state of Vermont forward. the state has a very significant and impressive set of resources and a real history of investing and building infrastructure, analytics, and people focused on care delivery and cost containment. And so it is a great pleasure to be here and talk with you about that as you move forward. And as Senator Kitchell mentioned, I was most recently the executive director of the Maryland Health Services Cost Review Commission. I spent 6 years there. I came to the commission right before it implemented its all-payer global budget model, and I worked through the implementation of that model and then the negotiation of the total cost of care model with the federal government. Prior to the commission, I really spent, I've spent about 40 years working in the healthcare field, focused on payment and delivery models and rate setting and other data analytics, cost analytics, et cetera. So that's just briefly my background. And I have a very simple PowerPoint, which I put together to hopefully walk us through the discussion. And of course, we'll be looking to you all to step in where you want more clarification. I was planning to, since you have a copy of it, I was planning to just walk through it unless Senator Lyons would prefer to have it put up on the screen. So I would just ask if that's the best way to just flip through it together, or would you prefer to have it up on the screen? Are we good?
Lyons, are you okay?
I'm fine. I have it on my iPad. I'm going to go through it with everyone. So whatever works.
Well, terrific.
Being able to see.
I agree. I would prefer that too. So we have copies.
Okay, great. So just to, I wanted to just start by, setting a little bit of context and some caveats. And in terms of preparing for this meeting and thinking about what is the state of Vermont is up to, I spent a good bit of time talking with Rachel Block, and I also talked with Dr. Lisa Watkins to get some good background. And I've read dozens of reports on the Green Mountain Care Board website and from other sources, and looked at some other data sources. So that makes me a good reader of multiple reports. It doesn't make me an in-depth expert in Vermont. So I just wanted to set that stage, and so I'm here to help frame the questions. I'm not here with all of the answers. So I just wanted to kind of set that stage for the discussion. So with that, and I would also ask that Rachel, if you have a comment along the way, please feel free to jump in with it. With that, I wanted to move to the third page of the handout, which is really the overview of the key questions. So as you're considering where you are and where you're going in terms of the cost and delivery system, I had 4 questions that I thought would need to be answered sort of in a sequence to think about what changes you might want to make or what directions you might want to take going forward. And so the first question, and I'll get to each of these questions in more depth on a subsequent page of the handout here. But the first question is, what's driving cost growth? So what are the big cost drivers? Because they're changing, and that may affect how you want to approach things. The second question is about the cost levels. So in terms of thinking about what are the best opportunities to reduce cost and cost growth, because you have to go after the big dollars, because that's where the spending opportunities are. But you also have to go after things that are growing too rapidly. And then after looking at those analytics and qualitative and quantitative analytics, then focusing on the experience and scope of the regulatory authority and the personnel of the Green Mountain Care Board and other constituencies, because you have other constituencies in the state that are part of the reform approach that you're taking, the ACO, for example. And then, of course, you have the Medicaid agency, which also has a number of capabilities and approaches that it's taking. And then finally, the final question that I framed here are, what are your goals? What are your future goals? Are they containing cost growth? Are they cost reductions? How can the structure and the authority and the performance be improved? How can you change to realize the opportunities that you've really thoughtfully invested in over the past years? So that is really the questions that we framed here to think about. Are there any questions about that before moving on to diving into the details a little bit?
I'm not seeing any, so please keep going.
Okay, so the next, so I wanted to dive into what are the factors driving cost growth. So here we're talking about information needs. What information do you need to understand the cost growth? And so I'm suggesting that you need some comparative cost data. So how do you compare cost growth data? How do you compare to other parts of the country, other similar areas? It needs to look at all spending, but then spending by category, spending by purchaser, and especially important is the per capita spending. When I looked at some of the reports, you've had a tremendous change in who is covering the population. So there's a tremendous shift toward Medicaid over the years. So if you just looked at cost growth without looking at the cost growth per capita, you could come to a wrong conclusion. So I think the issue is getting to that per capita by payer, and some comparative data is very important. And then another issue is really deciding on the source of truth. Now that may sound like a strange proposition there, but as you start getting into looking at healthcare data, there are multiple sources of spending data. And so it's extremely important to decide which is the best for the purpose at hand, what costs are going to be included, what costs are going to be excluded, what is the source of that data, and then really kicking the tires to make sure that the data is accurate as possible. And I will tell you that this is not an uncommon issue to tackle. For example, when I was working in Maryland with CMS, there are at least 4 different expenditure files on per capita spending for Medicare, and each of them is a little bit different and has a little bit of different answers, et cetera. So I think it's a very important thing to agree on the source of data. Otherwise, you can end up in a lot of different directions. Then in terms of also looking at cost growth, I think we want to look at the total cost growth because we want to go after the big increases, but we also want to look at things that are growing at a high percentage because those are the areas that we are going to want to try to tamp down in terms of, and they may require new sources of resources. So, and we want to look at it by payer because one payer may be having a good experience in per capita growth, but then maybe Medicare is low, but maybe the private sector is high. So I think we need to look at what's being experienced in each major purchaser community. And to the right of this slide 4, there, I put a little chart that I clipped out of the very large expenditure analysis of the Green Mountain Care Board of cost growth between 2018 and 2019. So you can see at the top of that cost growth was, tell you it's mostly drugs. And so that was one of the largest cost drivers, followed by hospital spending. So the drug spending would be a very high percentage, while the hospital spending is a very large sector and will need to be an area of continuing focus. So that's just a very simple example of what's going on underneath the covers. And there may be a few other issues that you would also want to tackle in terms of looking at cost growth. Some may come out of looking at the analysis, but one area that's been somewhat of a problem around the country is in terms of practice, physician practice acquisitions have resulted in billing through the hospital at higher rates. Now, and that has driven up hospital costs significantly, and the costs for those services significantly around the country. Now, I don't know if that's a problem in Vermont because you do have regulatory authority over hospital revenue increases. But that is an area that is being looked at in some other places. And finally, on the cost growth side of points that I wanted to make is the area of long-term care and long-term services and supports. A number of states have already been really looking at long-term services and supports as those are services that are rendered in the home to help individuals avoid or delay going into a nursing home facility. And so there's a lot of focus now on trying to improve those services and ultimately to reduce the level of individuals going into long-term care facilities, especially with the aging population. So that is another area of inquiry that I would suggest.
May I ask a question?
Yeah, Senator Kitchell has a question.
Donna, I had obviously drugs stand out, and that's something that we've been struggling with for years. And one thing I have toyed with, actually introduced some legislation, didn't go anywhere, and that was for a small state like Vermont to implement a single state formulary for everyone. Physicians would like it, of course, because different payers had different, formularies, and they had to go back and match up the coverage with what they were prescribing. Do you have any thoughts about doing that? Has it ever been done? Of course, everybody's saying their approach toward controlling drug care costs are the most effective. So they want to keep what they're doing. You see, is there a model doing any kind of leveraging of that pharmacy market?
So, there's a lot of different strategies that states are using, and I can't tell you, Senator Kitchell, if that particular one is in use. I will tell you the most significant thing that is driving drug costs right now are specialty drugs. So these are
The biologics.
the biologics, and that is really driving cost increase. So I was just looking at some spending data last week, and there's a new drug for Crohn's disease, and it's really, for example, driving up the drug cost tremendously this year. So it was lower last year, and this year it's really ramping up. So we have the introduction of these drugs, and fortunately we have biosimilars, which are helping to bring the cost down of some of these biological drugs. But in the beginning, there is no alternative. So a formulary doesn't necessarily help you with that. I think ultimately, hopefully we'll be looking to the federal government to help bring some of those prices down. If that doesn't happen, I think the states will continue to have to explore strategies to get those prices down. But there are other tactics to use with the remainder of drug spending, which is also very large and growing. And some of those tactics with spending could be executed through your ACO with the doctors by creating tools. I mean, I think a lot of times the doctors do not know what the cost of the drug is, but the ACO can create tools. So, for example, there are medications that would treat a condition like blood pressure that cost $5 a month, and then there's another set that costs $50 a month, and there's another set that costs $300 a month. And just getting that information in front of the doctors is really important. And so that is another tactic that can be used. So I think there's multiple approaches. There are a number of legislative approaches that have also looked into trying to control drug spending. So I don't know if that answered your question, but.
Thank you. Senator Lyons has a question.
Right, so it does follow on Senator Kitchell's question around the formulary, and we will be at least Representative Lippert and I will be engaged in an access and affordability task force, and the top priority, well, one of the priorities is to look at prescription drug costs, and so this is extremely helpful. My question is that as you're talking about the need for information, transparency, and pricing, that it is the physician who needs to know, but then also I had a recent experience where the pharmacist could have intervened and given information. So there are maybe these smaller pieces of legislation that could increase transparency. And then finally, my question is regarding a statewide PBM. So right now we have various purchasing opportunities through insurance companies, through Medicare, the state, and I haven't read through all of NASHB's recommendations that Rachel Block has put up, but are there any examples of a statewide or a broader PBM?
So certainly the fragmentation of the formularies can be confusing, especially for the doctors, because the drug might be more expensive on one formulary and less expensive on the other one. And so that does create some confusion. And states have certainly implemented buying across not just the Medicaid program, but the state and local government employees to increase the buying power. So I don't know where you all are on that front, but that is a step that some states have taken to try to maximize the discounts and to standardize the formularies that are being used. So there, and as you said, Senator Lyons, NASHB does have a number of strategies that they've also brought out and recommended to states to consider in terms of the formularies. In terms of statewide types of activities, I personally haven't been involved in transformation of the private sector to a single formulary with the public sector. But I have worked to implement a single formulary for the state employees and for the Medicaid program, and it was successful in saving money. It did help with the doctors as well in terms of creating a more consistent information in terms of what's more cost effective. So, thank you. Does that answer your question?
Yes, thank you. It's very helpful.
Thank you. Representative Pugh.
This may not be a question, I guess, for this part of the slide, but I'm wondering, as we look at factors driving cost growth, where does quality come in? Where does access come in? If there are no mental health providers, if there are no, or if there are not enough mental health providers, then the growth isn't going to be happening. So, okay, we're looking at money and I'm looking at people. What's the health outcomes and what is the availability of services? And if that's not what cost containment is all about, I'll keep my mouth shut.
Well, I think you're right on point with that comment. I think the cost containment is all about quality and driving access to services earlier. So if you don't have earlier mental health access, you end up in a hospital, and the hospital is really not a curative situation for mental health conditions. So the access point is extremely important. And in terms of looking for avoidable costs, which we're really getting, and I think we're actually ready to go to the next handout page, because this really flows right into the conversation on the next page, is really looking at, one of the things is looking at avoidable cost, and a lot of the avoidable cost is related to prevention. So are people ending up in the hospital with pneumonia? That could be prevented. And so these are linked to primary care and mental health care and long-term services and supports. So if we improve the delivery system on the front end, then that high percentage of cost that's spent in the hospital ought to go down. So that's really the that's really the gold standard of what we would be trying to do in terms of cost containment, is driving the cost down on the back end by making sure that we applied the right resources, the good patient care resources on the front end. And so the focus here in terms of looking at the cost opportunities is doing some benchmarking. We can look at averages, but really what we should ultimately look at is better performers, better cost and quality performers, and develop our plans from looking at that information to prioritize what are the best opportunities to reduce cost and improve the delivery. A second thing that I'm suggesting that we would want to look at is the current state of incentive alignment, because getting the if the state has goals, how are those goals reflected in the incentives that are being that are being used with the hospitals and the doctors in the state? Are there ways that we can make sure that the incentives are built in to improve the health and to reduce the avoidable utilization? And I found that was particularly important in Maryland to really drive investments. Without those incentives, it's easier to stay where you are than to move to where you need to go. So the incentives help to encourage the movement to reduce avoidable utilization, like pneumonia in the hospital. Then Vermont has invested a tremendous amount of money and has been a real leader in implementing changes in the primary care delivery system. And so the question that is asked here is, are we able with informatics, along with the model that we have in place, are we able to utilize that primary care investment effectively and maximize the return on it? So we just talked about drugs. So are we using the investment in the analytics to help optimize that wonderful investment that's been made in primary care? So that, again, that's a question. And then next, I would suggest, as we've just been through a massive period of change with COVID, to look to what has been learned in the COVID period that can actually be instituted more permanently into the system, and that can reduce cost. And also to look to providing more healthcare services outside of hospitals as a way of making them more convenient for the residents, but also making them ultimately more affordable. And then looking at the state of addressing social determinants of health, and again, back to that long-term services and supports and transportation as we look for opportunities to improve the delivery, make it better for the patients, and the population, but also to address spending. And so I have the question here, are there other things that aren't on the list here that I left off that you're thinking about?
Well, question to us. Housing. Senator Kitchell.
Well, are seeing in a variety of ways where hospitals become the default because of external conditions. One is more recent, and that is our nursing home costs went down. That's because nursing homes can't afford to retain the contracted nursing. So they've actually had to constrain admissions. So what is happening, I've been told, is that patients that really need to move into that level of care are ending up for prolonged periods in hospitals because of the fact that we have a national workforce shortage. So it's kind of an interesting, and mental health has just been a horrible experience in terms of individuals ending up, for sometimes several months more in emergency room settings. So it's interesting to see some of the factors can be controlled by the state. Some are not unique to Vermont and have that external impact that become sort of like prisons have become the last default. Hospitals and emergency rooms have both in those two cases have become the default provider of care. And so that's concerned because that's not the right place for the care to be provided. But in the absence of an alternative, it's the only care. And so that's the other struggle that are influencing hospital utilization and costs as well. And it would be interesting to factor that out if we could get a fix on exactly what has been that impact on hospital spending, because it gives you a sense of how much is being spent, which right now isn't, maybe more hidden, and to say, well, if we've used that money in this way, we're spending it, but not in the right way. I guess that gets into the analysis of that you're talking about.
Yes, I think that's a very good observation, and it does. And with the aging population, you can only expect workforce issues to grow, and that's why it's so important to really start or continue to think about how to provide long-term services and supports in homes and more services in homes, and using more telehealth and using what some are calling mobile integrated health, so that we're using more mobile types of resources to help serve the population. So, treating people at home with mobile health instead of taking them to an emergency room, for example. So there's a lot going on trying to move the needle on that front. But the cost analysis could help bring out how much you're spending on emergency admissions and medical admissions, because that really is where you can save money and also make it better for the patients.
Thank you. Representative Lippert?
Yes, I want to pick up on the issue of long-term care and its relationship to healthcare costs. I'm noticing I'm not sure where to look. To be honest, so I'm looking over here and hopefully this will work. So can you, from your experience in Maryland and looking more broadly, what is your understanding of the inclusion of long-term care costs as healthcare costs? How consistently is that factored in as we look at what are the costs of healthcare? Because in some ways, sometimes long-term care costs and long-term care in nursing homes or avoided long-term care or avoided nursing home costs, which we've done, I believe in Vermont, a fairly successful initiative around, those get excluded from healthcare costs. They're seen as different than healthcare. And I'm interested in what your observation is, and maybe even your recommendation is in terms of where the boundary of definition is in terms of healthcare costs, and then that influences a lot of these questions as well.
You're exactly right that it is a question that has to be approached, and I think it gets back to the earlier page that talked about deciding on the source of truth and what you're going to measure in the cost, and doing that in a consistent way, and who is responsible for that particular cost. So as an example, at the Health Services Cost Review Commission, where I was the executive director, we were not focused on long-term care, but our Medicaid colleagues were focused on long-term care and long-term services and supports, and so it is, and we were working on a process to begin to include that in the measurement process to see how we were doing. But it was not initially included in our measurement of our cost growth and our total cost of care. But it is nursing homes, to the extent that they're just past the hospitalization, were included in the cost, but to the extent that they're long-term care and beyond that hospital discharge period of about 30 days, we didn't initially have them in our cost data. So I do think over a longer period of time, they will have to be in the cost data with an aging population, and as investments there may reduce some of the other costs in the system, they will ultimately have to be looked at, even though another group of people in the state may be focused on them.
Thank you. Senator Lyons, is that a new hand? Have you raised your hand again? Okay.
I did. Just briefly, a couple of comments, because this is an area I think of tremendous concern for all of us, and that is what we think about as continuity of care and what works. You know, what are the clinical outcomes that we are seeing when one moves from hospital care or physician care to counseling and or long-term care services. So it raises the issue of alignment between and among payers, so that there are some consistent understandings about primary care or even specialty care, and then those services that are community-based, and how many of those community-based services might be covered by one's insurance within the system itself. So the question of alignment for me becomes very critical here, and how we make a determination, for example, about appropriate substance use disorder, mental health, or long-term care supports. So just a comment, I think this opens up a huge discussion that our committee has had in the past, and I think it's important for us at some point to try to wrestle with this. And I think the Green Mountain Care Board is going to, at some point, have to wrestle with it, and perhaps DEVA and DFR. I mean, it's everyone together. So that's all.
Yeah, and that's and I did learn that your primary care model does have some continuity and moves across into the long-term care setting. So that was actually very impressive in terms of one strategy that Vermont has implemented ahead of some others in terms of trying to create better continuity. Dr. Watkins was telling me about that strategy that's been implemented. So that's very excellent. So,
Just a minute, Donna, one more.
okay, sorry.
Yeah, obviously, some of us are here, and sometimes cost is actually constrained by budgets. So like our mental health agencies, they get what we give them, as opposed to, proposing a budget and having it reviewed. And then you made a comment, if you have a competition, and we don't in a variety of areas, then you need regulation. And I wondered if you could expand on how you would see that regulatory presence relative to what we have in place.
That may be a segue to the
Oh,
next
maybe
slide.
I'm not on the right. Maybe I should wait and get to the next slide. But one of the things that obviously the creation of the Green Mountain Care Board was done back in a different environment when we were thinking we were moving to a single payer. We're not in that environment now. Obviously, the cost and growth in healthcare, you've seen the articles, et cetera, have been of concern. And yet juxtaposed to that are small hospitals that are saying that they're on the verge and one filed for bankruptcy. So your comment about, because we're really not in that competitive environment, nor would it make sense. And you made a comment about, and we actually experience this with insurance companies. We have a very small market. Why would we don't have a lot of competition. Because it costs money to have that kind of presence. So I'm just wondering, in terms of the structure that we have in place, what we've seen for trends, and your experience in that regulatory realm, and your comment, which really struck me, and that is where you don't have competition, then regulation takes on a more important role.
Right, and you have structured things in that mode in the state, and I think the next slide does actually get into the scope of regulation and authority, and so the first question of inquiry is, are the cost growth targets that are driving your system, are they appropriate? So that's something to look at in the inquiry. And then, are they being achieved? So are they appropriate, and are they being achieved? And in the aggregate and by payers, so that it's not just one payer's doing well and everybody and another's not. So that's the first question here. And as you said, targets are a balancing act, because you do have on the other side of the target, there's wages and there's drug cost, and there are things on the other side of that target, and so you have to be the ones to set the goal of what you want to achieve, because there's things on both sides. So the important part is trying to also determine what cost do you want to eliminate or reduce. And so that's why it's so important to look for opportunities for reducing avoidable utilization or waste in the system. The second point on the slide is about the hospital cost. Hospital cost is going to be on the list, regardless of any list that you put together, because it's so large as a percentage of the total cost. So it is the regulatory approach and authority reducing the hospital cost growth and the use of hospitals. And is this a top priority for you? And I think the answer has to be that it needs to be at the top of the list, because it's such a large cost. And the growth targets that are applied to hospital budgets, are they aligned? Are they appropriate? And do they produce the total cost of care growth targets? Are they bringing you in on the total cost of care targets that need to be delivered? So that's the second question. The third, underneath that too, is the CON program. You have a CON review program. Is that program now focused? I believe a CON program in this environment with so much care moving into the home and out of the hospital ought to be very cautious about building capacity when we're in a period when more patients are being treated in other settings. I've personally seen new hospitals built, and 2 years later they have 60% occupancy. And so is the CON system delivering to make sure as you look down the road that you're not putting too much money in bricks and mortar, and that you're putting more money into those mental health providers in the community setting, or getting the supports into the home, et cetera. So is the CON program delivering? And can you improve your value-based programs to reduce the avoidable hospital use and cost? So, and that gets into the question is One Care Vermont on the way to reducing avoidable use and cost? How are they doing? What's the track record? And obviously also what is the enrollment? If the One Care doesn't get a high percentage of the population under enrollment, then you won't be able to realize the benefit of having the doctors look at that information-driven process of these are the patients that we could help and it would avoid hospitalization, or these are the drugs that we could use that would be more affordable for our population. So that is another question along the way. And moving on to the next page, as the regulatory authority questions continue, it's how does the regulatory authority line up with and the capabilities line up with the cost increases and the opportunities? And so do we have tools for drug costs? We have talked about that extensively earlier, and home and community services and the mental health system, which we also talked about. Does the Medicaid agency have the tools and the flexibility it needs to use the funds that come from the federal government to redirect them as needed to things like social determinants of health and long-term services and support? So those are the regulatory authority questions that came forward on my list. I don't know if you have other thoughts or others that you're thinking about.
I am not seeing hands or other body motions that tell me that there are other questions or thoughts.
Okay, so we'll move. So we can move to the final discussion slide, so we've spent most of the time talking about the what. So what are the costs and what's going on, and the so what of so if we have the facts in front of us, what do we need to think about in terms of the regulatory structure? And then the now what is so as we move forward and we're trying to optimize the system that we've developed, what are the goals that we want to drive that system? And do the goals need to be clarified or adjusted from where they've been in the past. And then finally, what structures need to be changed or enhanced to make sure that we're realizing the opportunities from the investments that we've made, and then also closing any gaps in the performance versus the expectations. So that is kind of the final step of an approach. So that concludes the PowerPoint discussion, and I would again open back up to questions or discussion.
Thank you very much. Senator Lyons?
Yes, and thank you. This is very helpful. So you're talking about closing the gaps, and you're looking at the qualitative analysis to improve healthcare. Do you have a sense, as you're looking at our quality data collection, either at the Green Mountain Care Board or at the ACO, do you have a sense of what are the best metrics? Do we have the link that we need between the collection of data and then informing our practice, our medical practitioners? I hope I'm clear, but it's the question about, making the link between the collection of data and then the actual improvement itself and the measurement that we have in place. What are the things that we need to do for improvement there?
So I haven't actually examined exactly what you're doing, so I can't give you an answer, but I can tell you that in terms of what we did in Maryland, is that we really focused heavily on how to, we met with the doctors and we focused heavily on how to get information to the point of care. So that is getting information on the patient at the point of care delivery so that the doctors can actually execute the work that they need to do to care for that patient the best, and on getting information to the doctors to say, this patient needs this, or this patient's been to the emergency room, you need to reach out to this patient, or this patient's on this set of drugs, there might be a set of drugs that are less costly that would do the job. So really a tremendous amount of focus on taking that data and information, including information through the health information exchange out of medical records, and getting that to the point of care. So that would be really an area of focus that I would recommend to ensure that the doctors are and providers are getting the information they need.
So from a public health perspective, then we would be looking at a broader clinical, sort of the clinical basis for treatment of one disease versus another, because our goals are related to as a public health initiative rather than individual patients. And we do have a prescription drug detailing program that works very closely with a number of physicians, particularly primary care. And so I'm trying to think about the best way, and if you've seen anything in other states, for disseminating that kind of information to then demonstrate a public health improvement overall.
Well, I'll just give you an example of something that Kaiser Permanente does that we were trying to do in Maryland. So if you walk into a Kaiser Permanente doctor's office, and if you have high blood pressure or you have uncontrolled diabetes, or if you have not had your preventive services or vaccinations, that's a piece of information that comes up immediately and consistently. Of trying to drive the health of the population by bringing that information consistently and repeatedly to the providers. And so that's an important capability that is that starts with electronic medical records, but there's a lot more to getting it to the point of care. And so those are some of the strategies that, if you're not optimizing that wonderful investment in primary care, that those are getting the data at the point of care is critical to actually realizing the full value of the investment and avoiding waste by having people end up at the hospital who could have been treated in the office. So.
Representative Ansel.
Thank you. And thank you for the presentation. It's helpful in beginning to think about sort of how to approach this. But I'm stepping back just a little bit. I think as a legislature, we're pretty good about setting goals. I don't think we're very good at analyzing whether we're achieving them. I don't think that's really where our skill is. And so the question for me continues to be, do we have the right regulatory system in place to achieve the goals and to help us determine whether we're making progress towards them? So I guess I'm sort of restating the problem, and you're helping us get there, but I'm still left with this question about how do we decide whether we have the right regulatory structure in place? Because we can't do it. We're not regulators.
Right. So I think sorry.
I thought Bill was going to add, no, but I beg your pardon. Please respond to Senator Rep. Ansel.
Whoever you are.
So I guess what we were suggesting here is really a process to examine whether you're meeting the goals and whether you're containing cost and how your cost containment compares to others, and what the cost drivers and the cost opportunities are. So that really needs to be done in order to drive the discussion of how does your regulatory system need to be adjusted. So you have to have the answers to the first questions before tackling the second questions of changing the system. So you've spent a lot of effort, for example, building up excellent data collection and analytic resources, and those are really important resources. And then, you want to make sure that you keep the things that you need and adjust the things that are going to take you to the future. So that's what I wanted to say.
Rep. Lippert and then Senator Cummings. And I'm also mindful of the time but we'll make it all work. Thank you.
Okay. Yes, I really appreciate Representative Ansel, your question. I've been sitting here thinking how frustrated everyone continually is that the cost of healthcare having been reduced, or they certainly haven't been reduced, but perhaps they've been, the trajectory has been reduced perhaps, but there's even questions about that. And how do we as a legislative body evaluate where the issue is? Because the frustration is widespread, but sometimes depending on where you sit, the solution is, oh, we must have the wrong regulatory structure. We need to change the regulatory structure. On the other hand, we as the legislature, I think at times don't have the resources actually. Frankly, I'm going to assert that from my point of view, I do not believe we have the resources sufficient to do the actual analysis of what, to come to a conclusion that's not just based on, to come to a conclusion that's based on some kind of data and facts. We're in fact reliant on other entities to give us that data. So I think we're in this complex dilemma of, is our regulatory structure sufficient, or does it need to be modified? Or is in fact our regulatory structure contributing, and at what level significantly or not significantly enough, to the goals that we've set? And how do we untie that? How do we sort that out? And I think part of it is, this is a much broader discussion that we need to have, I believe, which is, I think we as a legislative body are under-resourced in terms of actually having access to analysis. And anyway, so that's something I want to put on the table. I had a specific question in terms of when you were talking about bringing information to physicians, so that when a patient comes in the door, they immediately get this information. I'm interested in Maryland, what entity was actually responsible for actually bringing that about? Was that an entity that was set in motion by the legislature? Was it an entity set in motion by the cost containment group that you're part of? Is it voluntary? Are all physicians participants in that? Or is it a mandatory, all physicians will participate? In terms of getting the information, the analytics, et cetera, because I think those are some of the more nitty gritty questions that fly around here as we try to evaluate what we're doing.
Well, in Maryland, we focused, the health systems play a large role with the electronic health records of gathering and the information that needs to be used. And in Maryland, we have a health information exchange that is a public-private partnership. It is a not-for-profit organization, and it is funded in part by the state and the health systems. And it is a very functional health information exchange. We got a lot of matching funds from the federal government to help build it. And that resource brings the information, a lot of information to the point of care. It doesn't bring everything, but it brings a lot of information. And the regulatory body did require, for example, that the hospitals submit electronic data. If somebody arrives at the hospital, almost instantly, the HIE gets that information. If they arrive for an emergency room visit or an inpatient or as an outpatient, that information is available, and the physicians are able to be notified when their patient comes to the hospital, as an example. And the tools have been put together with the HIE to provide important notes about a patient, so that would also be available through the HIE. And the emergency room doctors, actually, our HIE is called CRISP, CRISP. And so the emergency room doctors actually say that they crisp it when they're looking up a patient's information when somebody comes into the emergency room. So it's a very functional tool that the doctors have become accustomed to using. And literally with the billions of dollars that have been spent on electronic medical records, the investment in making that HIE work really helps to make that a medical record investment pay off. So that's how, a major way that Maryland is focusing on bringing information to the point of care. I hope that answers your question.
Sure, I have lots of other, I could go on, and I would hope maybe at some point we'd have the opportunity to have that opportunity to hear more specifics, but thank you very much.
Thank you.
So, thank you. Senator Lyons, and then I think I'd like to turn to Chair Mullen in the Green Mountain Care Board.
Yeah, it was just a quick comment about our health information technology system. We do have a fairly comprehensive data set through Vital, but then we also know that our electronic health records are split between providers. So Blue Cross and Blue Shield with its own data set, and then other networks. So again, the word alignment for me becomes very important in trying to integrate more patient data and information so that quality analysis is done more holistically, but that's my own pet peeve. So.
So thank you. And Ms. Kinsler, are you able to stay with us in this next hour? Thank you very much.
Thank you very much for the opportunity to be with you today. And I am planning to listen to the next presentation and looking forward to it. Thank you very much.
Thank you for your presentation. It's been, I think, most helpful. Great framing of the question, some questions for us. So with that, let us turn to Chair Mullen from the Green Mountain Care Board. Members had some particular questions around the work of the Green Mountain Care Board and its relationship to the all-payer model. But I have a feeling that based on this hour's conversation, you may have other comments that you'd like to share. And I'd just like to turn this over to you. And again, if we can have kind of a free-flowing conversation, that would be terrific. Thank you for joining us.
Oh, it's my pleasure. For the record, Kevin Mullen, Chair of the Board. And I'm joined this morning by a few members of my staff. I don't see them on the television. Susan Barrett, could you introduce yourself?
Yes, Susan Barrett, Executive Director of the Green Mountain Care Board.
And Sarah Kinsler, can you introduce yourself?
Absolutely. My camera seems not to be working. I apologize, but I'll just say Sarah Kinsler, Director of Health Systems Policy at the board. Nice to see you all.
Super, thank you. And Susan is going to run the slide deck so that that will be on the screen as well. Sarah's her backup in case anything goes wrong. We try to build redundancy in all these meetings, and I'm really impressed with your technology.
And Chair Mullen, did you want me to start
Yes.
the slides now?
Well, and let me ask, because we have them in our hands and we rather like looking at people rather than having our.
Well, I figured since I'm here, you can still look at me.
But we
you
have
can one
Senator
screen
Lyons
and
and-
slides with people that are just watching.
Yeah, you wanted to, yeah, I understand that. Who are watching. Okay. So we'll turn this over to you.
So thank you very much. And this has been a fascinating conversation this morning. You really picked the right person to bring in. Thank you, Senator Kitchell, for arranging that. And we've been looking at Maryland ever since I think I was first on the Health and Welfare Committee with Representative Pugh. Maryland has been an example that this state has looked at to try to do modeling after, and has always been impressed with the work that they've done there. And, you know, when you have conversations with the federal government, like we are now, trying to figure out where we move forward with from here, model set to expire. They repeatedly talk about Vermont, Maryland, Pennsylvania as what they call the states that they feel are a little bit ahead of other states when it comes to reform efforts. So that's the work of the legislature. And I'll try to go through these slides as quickly as possible and focus it more towards the conversation that you've already begun this morning. But I was asked to talk about what we do at the Green Mountain Care Board so that you have an understanding. Some of you have heard a lot of this before, and I apologize for that, but not everyone has. So our mission is to improve the health of Vermont through a high quality, accessible, affordable, and sustainable healthcare system. And Representative Pugh really nailed it when she focused on what is the Vermonter, what is the person actually getting? And you can't just look at cost containment, although cost containment, believe me, is at the top of my list. You have to make sure that people have access to high quality care. And I would say that I agree with all the cost drivers that Donna presented this morning, but I would say the biggest single issue facing the state of Vermont, and we are not alone because this is a national problem, is workforce. And workforce at all levels. And different parts of the state are starting to see access issues because of the inability to recruit, whether it's specialists, primary care, nurses, social workers. It's across all lines in healthcare. And what you've seen now is you've got this pent-up demand that's been driven by a fear of going into the system. So the system is being strained at one of the highest points it's ever seen because people who deferred care for 15 months now want that care. And in some cases, because they deferred it, the care that they need is going to be more intense. So it's just like we often talk about focusing on where the money is. And we know that 80% of our costs are really driven by less than 20% of our population. And that's in areas of chronic illnesses. So if you can get to somebody before they have full-blown diabetes, if you can get them in a pre-diabetic diagnosis and try to address their care, through better nutrition, through exercise, some cases drugs, you can really drive down what that person could cost the system if they wound up in needing treatment in a hyperbaric wound treatment center, or God forbid an amputation or something like that. And so our mission really is that triple aim. And thank you, Representative Pugh, for really pointing out that it needs to be patient-centric, any system that you have. And so what makes the board unique in comparison to a lot of the other states? For one thing, transparency. All of our decisions are made in public. We're subject to the open meeting law. Staff recommendations are seen in public. We have our meetings taped by Orca Media. We post them to the website. Everybody can see what's been discussed. And through that transparency, we're better engaging stakeholders. And I was going to thank Mike, but I think he left the room. The Healthcare Advocates Office has been a great partner to work with as we try to make sure that our system is patient-centric. We also have that open transparency with our engagement with other state agencies like AHS, our regulated entities, and the public. And so when this board was created, and a few of you were here then, one of the things that it was.
We all were.
Not me.
Mary wasn't.
No, I was a baby.
Oh, except for one. I'm sorry. Well, except for one.
But
as you recall, the basic premise behind creating the Green Mountain Care Board was that it was rapidly growing as a percentage of the Vermont state domestic product, our economy. And we had gone from a little over 11% in beginning of the 90s to going close to 20%. And we already had in place what was then the Public Service Board. And that was a smaller portion of the economy. And the thought was if we could create a similar entity that was looking at this larger piece of the economy, healthcare, that it would make sense. And one of the things that was key to that thinking in the beginning was to make it an independent body so that you're not having flip-flopping reform efforts from administration to administration. Because unfortunately, as much as we all want it and we all demand it, change doesn't happen overnight. And that's the most frustrating part of our jobs at the Green Mountain Care Board is we want things to happen quicker. They don't happen as quickly as we would like, as you would like. I would say though that I did want to talk about a few measurements of, has there been any success? And Representative Lippert brought up that question, and it's always something that's hard to quantify. And when we were creating the Green Mountain Care Board, the discussion was never that it was going to lower overall costs. The question was to bend the cost curve. So if you take a look at what was happening in the state of Vermont for the previous decade from 2000 to 2009, hospital spending was growing at 8% on average per year. We were seeing this massive increase in a percentage of our state's economy being spent on healthcare. And then you look at after the efforts of the creation of a regulatory body, the Green Mountain Care Board, and what you've seen is hospital budgets have grown at about half that rate as they had previously. And if you take a look at overall healthcare spending in the state of Vermont, if you factor it at the same pace that we were growing prior to the Green Mountain Care Board, and you look at the period 2013, which is when the board was fully implemented, in 2019, which is the most recent year that we have finished data for, you'll see that if we had been growing at the same pace Vermont had been going at, we're 6.5 billion less in spending for those 6 years. If we grew at the same pace as the rest of the country, because you have to assume that there were other trends that were bringing costs down, like the Affordable Care Act, things like that. And you factor out if we grew at the same pace as the rest of the country, and then you subtracted where we were for those 6 years, that's about 2 billion. So at least I have to believe that we bent the curve somewhat. Have we been successful? No. And we're always working at the Green Mountain Care Board on a continuous improvement project to try to figure out how to do better. And so, but the independence, getting back to that, if you don't ever give enough time for a given project to succeed and you're always switching what your strategy is, then you'll never be successful. And the independence of the board allows for that more of a long-term view rather than this has to be done within the years of my administration. And really, the system-wide view is what is key. And we're going to get into the next slide about, I guess it's a few slides down further, I'll wait then. But I do want to say that if it's not integrated, if you're not seeing in your analysis of insurance rates, what's happening with hospitals and other things, then you're really not seeing the bigger picture. You can't integrate everything together. And so we've made strides. We still don't have a perfectly integrated regulatory system, but we've made progress. And the system-wide view really allows us to try to oversee innovative reforms seeking to improve quality of and access to care. It allows us to contain the healthcare cost growth, allows us to improve Vermont's ability to collect and evaluate healthcare data, and it promotes transparency and understanding. So if decisions were made behind closed doors, people wouldn't necessarily understand why those decisions were being made. So let me just use last year's hospital budgets as an example. So last year, we allowed changes in charges to have what I would call a higher increase than what has been seen in the recent past. But that's because we're looking at the fact that the cost to the system isn't just price, it's price plus utilization. And it was clear that utilization was going to be down because of the pandemic. And so the bigger focus was making sure that we had a healthcare system that actually existed coming out of the pandemic, because we could have kept hospital growth and charges to 3%. Certainly had the authority to do that, but if we did that, what kind of shape would those hospitals be in coming out of the backside of the pandemic, hopefully? And so that was a key underlying factor in those decisions, and that's really what we're talking about with the system-wide view. And what you saw is a number of hospitals had lower utilization, so that their costs were actually less than what they had been the previous year, even though they had the higher increase in charge. So the next slide.
Chair Mullin, a question here.
Yeah, before we move on, I wanted to really focus in improve Vermont's ability to collect and evaluate healthcare data. And going back to your earlier comment, certainly those of us who have been part of this discussion for a long time, and it's really the whole, concept behind the blueprint for health, and that is the a medical home, the ability to avoid emergency room utilization. There's been a lot of data, and there was evaluation that Dr. Jones' staff produced and so forth. So my question is, you're looking at that system-wide view and the comments that were made by Donna in terms of what we need for areas of inquiry, those trends. For example, we all agree that we should be doing as much as we can upfront to avoid. Are we making progress? I don't have a sense in terms of if I were to say, is that being reflected in terms of the data, in terms of hospital utilization? And how do we, what are those benchmarks for that, to get back to the comment about, we should have those benchmarks. So I was just interested in trying to crosswalk this system-wide view and the data and the comments that were made by Donna in terms of how we actually utilize the data to inform us as we're moving forward. So I just wondered if you could speak to that role that the board plays relative to the testimony that we just heard.
Sure, I can. And that's, I would say if you spoke to each one of the members of the Green Mountain Care Board, they would say that the most frustrating aspect of the decision-making is the reliance on data that is not completely up to date because there's such a long run out in claims experience and things like that, but also that's not complete. So for example, we're getting the claims data, but
we have that all payer except for one, I think, insurer.
But the problem was Vermont lost the decision, if you remember the Go Bay decision, that
have more insurers bail then?
Several have bailed. We have reached out. It's not insurers, it's companies. And these are the self-insured ERISA plans, which are the lion's share. So let's talk about the insurance market. Everybody thinks that we regulate the whole market. We don't. What we're regulating is about a little over 72,000 people in the individual and small group market. And then we're regulating the large group market. But the vast majority of coverage of Vermonters in commercial and insurance is ERISA and self-insured plans. So these companies don't have to report into the system. We started at the Greenmount Care Board, Sarah Lindbergh, who's in charge of our data team, and I made calls to companies and asking them if they would reach out to their insurers. We reached out to companies like Aetna just to make sure that they wouldn't place an additional charge on these companies if they reported. And we got a pretty good response, but we're still not at a critical mass where we're seeing the biggest percentage of self-insured information being reported into the claims database. So we're still missing that. We're going to continue to work on that. We kind of took a hiatus during the pandemic from getting people to do things because it was next to impossible. They were so focused on, how they were going to run their companies remotely and things like that. But we're going to get back to that. And we did have success from a number of the companies that we reached out to. And, it doesn't cost them to do that reporting. Their insurer would do that for them. I shouldn't say their insurer, their third-party administrator. And so, that's one of the frustrating things. And that's on our view of, being able to analyze analytics. And we've looked at, so for example, we've seen analysis done by Rand Corp. We hired Burns and Berkeley Research Group to do some data analysis for us during the rate review process. And it's the one part of it can be kept confidential. And that's because Vermont state law allows confidentiality for things that could give somebody a competitive advantage over one of their competitors. So insurers, the carriers won't have that discussion in public, but we get to see the information confidentially and look at it. And there are some conflicting information between all these different data sets. They don't all align. And that is so frustrating. And those are the conversations that our data team is having now, trying to figure out how do we get this all to align so that one isn't leading you in one direction and another data set is leading you in another. And that filters down to Senator Kitchell to
well, that gets back to
with the doctors when they're logging on. A doctor doesn't want to open 3 different screens.
Mm-hmm.
And that has been a continued problem. And you think back to when we first were talking about electronic health records in the state of Vermont. If at that time we could have said everybody must use this system.
I advocated for that.
So did I. But
I lost on that one too, that we should have 2 or 3.
The federal government told us we couldn't do it.
I think the federal government could have, the federal government determined meaningful use, which drove everything, but we could have said, we will only support through our vital system 3 designated entities. No one was willing to do that.
So much better.
In hindsight, everybody said we should have done it. So I agree, meaningful use drove a whole lot of products, but we could have said, we're only going to support these 3. But
what the federal government was also telling us is that we could mandate a platform, but we couldn't mandate a provider. So,
oh well, that's past history.
yes.
So Rep. Pugh has.
You started out by saying the universe of individuals are sort of small because, well, not small, but because
It's just not complete.
it's not complete because the ERISA and the self-insured don't have to participate or whatever. And some choose to and some don't. So is that public information as to, is there any reason why the legislature couldn't know who were the companies or who were the,
I'd have to ask my general counsel that.
you know, I mean, I do hope
But I can
UVM is
get back to you.
participating.
I can get back to you and ask you if it could be public information.
I mean, you know, and if there is a role of the legislature.
Well, I don't know what role you could have since there is a precedent set by the Supreme Court, but.
Yeah.
You know, maybe Jen has a brilliant legal idea.
But you're just talking about public information about, well, the court decision exempted you, but public, here are the people.
Here are the people who
But it raises.
These are the Vermont corporations which are not participating in us moving forward with our complete health data in order to
Yeah,
this Vermont.
Something along that, you've got the
It's kinda like
script
that
there.
wall of shame that we created on prescription drugs,
Yeah.
where we got out that list.
So just to add
A voice.
idea, a voice out of the screen. But I did ask Jen to write a letter on my behalf to the federal government, which it hasn't happened yet. But one of the dicey things is that Go Bay decision that has kept us from accessing that data. So, and I've asked to give us some authority similar to what Hawaii has, where they can access all of the ESI data. But yeah, this is not an easy.
So I'm a wee bit concerned
And
about
I think Jen is
time.
probably as frustrated as we are.
Yeah. So we're flagging understanding data and wanting to have better access to it as an area that needs to be interrogated farther perhaps by us or the Health Care Task Force. Yeah.
Okay, so
It's
Susan,
just, at least one member has to leave at 11, and I do want to just create a window of opportunity. So we'll have our conversation and maybe we can go over, but I just wanted.
and I can always come back.
Yeah.
Don't want to go too far over, only because we have the
You have work.
certificate of need hearing this afternoon on the residential facility in Essex. So.
Yeah. You can't, you have to be somewhere else.
Yes.
I mean, the Department of Mental Health.
Yes. The secure residential site, seal in here.
Yeah.
So the next slide is really trying to put on one page what we're doing. And we've already talked about our mission about reducing the rate of healthcare cost growth in Vermont, ensuring that the state of Vermont maintains a high quality, accessible healthcare system. And in the big bubble, you see all the different pieces. And so most people are very familiar with the rate review process. We're in the middle of the QHP filings now. We'll have a decision out tomorrow on those. And I did want to just flag one of the things, because prescription drugs has been a huge cost driver, and Don is absolutely correct. And it has been specialty drugs. And these are wonderful life-saving drugs, but they're very, very expensive. And I will say that a good piece of positive news, when you see the Blue Cross decision that will be out this week, they were actually able to lower that particular actuarial measurement of the cost of their policies, because they moved from Express Scripts to OptumRx and are seeing tremendous savings that are really going to pay good dividends for their policyholders. So the small group market will definitely see a decrease in the individuals. On paper, it will be an increase because of the ARPA subsidies, which I hope everybody's promoting with their constituents, that they really need to get on and use the online tool comparison, that those enhanced premium tax credits are going to make it so that a good portion of Vermont is not seeing any increase in their insurance rates. And of course, that's only for 1 year. We don't know what the federal government will do, but hopefully they'll see the benefits to that. But I will bring up, just because I think you need to know this too, that with every piece of good news, there's also bad. So I have been reached out to by some pharmacists that have concern, and they believe that even more independent pharmacies are going to close in the state of Vermont. So Blue Cross believes strongly that the savings are due to the rebates, and they may be accurate. But again, we only have some pieces of information so far from an independent pharmacy that shows, like on one particular drug, that before the sticker price was $14.97, the reimbursed price under Express Scripts was about $1,100. The reimbursed price under Optum is a little over $700, and they're saying they're putting that out at a loss. And so, you know, obviously the first question is, why would you do that? And of course, they have to take everything that comes their way if they're going to be participants in that program. And so this is just one drug. He also didn't share with me any examples where he might
Have some offsetting.
Yeah, so you don't know, but again, I just want to point out that we are getting that feedback from independent pharmacies that are struggling. So we we have the ability under statute, we have the general advisory group that's specifically listed in statute that meets quarterly. And then we have the ability under statute to set up technical advisory groups. So an example of that is the primary care advisory group. You would put that in statute, but it had a sunsetted time. We used our ability to keep it going as a technical advisory group. And another one that was set up this past year was the prescription drug advisory group. And that has been split up into two working groups now that are working on different areas with possibilities come back that we could present to you as things that could be done in the state of Vermont. I will say that nothing is wowing me at this point that I'm hearing from the groups. So, but we're trying. And again, that, you know, anything that can be done, when you look at other countries, why they're successful at having much lower drug costs than we are here in the United States, they're willing to make hard decisions. And here in the United States, we don't ever want to limit anybody's choice. So in another country, you know, there are a number of different statins that will work. And other countries are willing to say, okay, whoever gives us the absolute lowest price is going to get the business. In Vermont, in the US, we're not really willing to do that. And, you know.
Sure didn't with the Medicare Part D.
Yeah, and we can go into a whole laundry list, but I don't think you want to hear that today. But there are things like, I don't think we need to see all these things advertised on TV. We need to, you know, close up some of the loopholes on getting things to generics, all these things, but those are things that you can't do. Believe me, we tried to do it when I was in the legislature. We never made any progress. But getting back to this, going down through hospital budgets, they have been submitted. This year, we gave the ability for hospitals to have a presumptive approval of their hospital budget if they met the targets that were put in place, which was 3.5% or less on an increase in charges and a 3.5% or less in net patient revenue fixed prospective payments. Two hospitals came in with meeting those targets. They were Gifford and Northwest. And you'd say, well, only two, that's probably not a good thing. But on the flip side, those are both hospitals that have struggled in recent past. And so it's a very good thing that they came in. So they won't have hearings. The other 12 hospitals will have hearings beginning August 16th. And then we'll start deliberating September 1st. We'll have votes completed by September 15th, and the written decisions will be out by October 1st. But unfortunately, what we're seeing in those hospital submissions is they're higher than we would like. Of course, everybody would always like them lower, but we haven't been able to have that process yet of going through each one. So, you know, you have to look at every hospital as a unique situation. There, you can't lump everybody all in together. First of all, we have 8 critical access hospitals. We have our PPS hospitals. We have our academic medical center. And so you can't look at them all through the same lens, but even that isn't even the biggest variable in this year's look at hospital budgets. What you're seeing is that every hospital was affected differently by the pandemic. So if you were a hospital that didn't do a lot of preventive screenings and surgeries or things like that, you had less of a hit on your revenues than another hospital. Then you had only a couple hospitals in the state, because of their small size, were able to get PPP dollars because they had less than 500 employees. Most hospitals were not able to. Then you had the fact that UVM was treated as a metropolitan area versus Dartmouth, which was treated as a rural tertiary care hospital. So UVM initially didn't get really a fair shake on those dollars. The state of Vermont, through your efforts in the administration, has tried to make them in a better place. But it also, what you've seen is, so for example, North Country Hospital did not have the same length of time where there was a hesitancy by Vermonters to go back in and access care and prevention and treatments there. Whereas if you lived in Burlington and you had those higher incidences of COVID and things, UVM had a longer period where people were staying away from the hospital. So of course they had other issues that also have impacted that, like the data breach and the air handling failures at Fanny Allen Surgery Center. So that's impacted their revenues. But each hospital, to make a long story short, each hospital has to be looked at individually. That's what we do. In addition, we look at the ACO budget here in the state of Vermont. We are charged by Act 113, which we passed, to both certify an ACO and then to review and approve their budgets.
Kevin, could I ask a question about
Sure.
that? The legislature in the past has prescribed certain activities of the board. And sometimes we've questioned, have we given you the right assignments? And as we look through in terms of the documentation on, you know, the all-payer waiver, the extent to which we have created an internal, and I think there was a letter sent by Senator Lyons around that effect. Have we, I guess the question I have, and maybe you're not prepared to answer it today, but in looking at some of those roles that we have given the board, have we actually created internal conflicts of roles? Sort of, I hate to use the example of the EB5, where you're the regulator and you're the promoter. And if we look through here, you're participating in the negotiation of the waiver, which involves an entity that you have to regulate when you get into that one ACO. And as Donna said to us offline, in a small state, just like you don't have a whole lot of insurers, you know, there's not a market for a whole lot of ACOs. So I guess what I'm wondering is, as we look at the structure of the board and some of the assignments over time that we have given to the board, have we put you in a situation where, in fact, it has made that regulatory oversight and that decisions and the analytical work that you have to do, has it in fact put you in a conflict of interest role? And I'm just going to put it out there that certainly as we're looking at it, you know, you're going to participate with the federal agencies with the administration. You know, you've got We've given you a variety of things that you're talking about. You're a signatory. And for me, it raises a fundamental question as we look back and things get added on a little bit here, a little bit there, whether we have perhaps we need to relook at some of those statutory assignments.
So I would say for the most part, I think you've been very respectful of what is possible in the assignments that you've given us. Of course, we always panic at the beginning of a legislative session when we see everything new that's being proposed that we should be doing. But at the end of the day, I would say a number of the responsibilities that you've assigned to us are really things that we would be doing anyways. So like the Rural Health Task Force assignment was a great assignment. Now you talked about the EB5, and that's something that I spent a great
But shouldn't
deal
our
of time
Department of
thinking
Public
about.
Health, I mean, our Department of Health, well, did we move the HROC over to, I can't remember who we gave that to, that statewide health plan? We used to be called the HROC from years
Are you talking about the
ago.
health resource allocation plan?
I am.
Yeah, we do that.
Okay.
And tremendous amount of work, but something that needed to be done. And the great thing is working with the healthcare committees, we really re-envisioned what HRAP is, because it used to be.
That sounds better than HROC, right?
It used to be this inventory of what was in the state of Vermont that was put into binders and sat on a shelf and was never used. And we're now trying to, through our data team and through providers around the state, we're trying to make that more as a living and breathing document so that as things change, they can be changed. And it's not something that was static from 2009. It's something that's more current. And, you know, our primary use of the HRAP is in certificate of need discussions and for figuring out if it fits into what's best for the state of Vermont. It's a Herculean task to do the HRAP, but it's something that I think we should be doing. And so I don't think that it was improper, but I do want to address the whole EB5
Can I
issue.
quickly ask a question
Oh, sure, go ahead.
while you're talking
ahead.
about the HRAP and the harumph and the data? Yeah, I know, it's fun. But data collection through the Department of Health would provide information about our health outcomes. And I'm wondering to what extent the board works with the Department of Health to access and collate all that data. So, you know, so I sit on the fence with this one, because I really think obviously having the HRAP available for CON is critically important, but the Department of Health has some of the very critical data that we need to understand quality outcomes. So just if you could comment on that really briefly, or it may be not at this time, but it's something that.
Sure, the Department of Health they're extremely collaborative partners. And, you know, I can't think of a better example in state government than the Department of Health that really does work collaboratively. And we could not even begin to do the health resource allocation plan without their efforts. So our team is working with them to do that. I do, and even like things like when we are trying to figure out a way to pay for something to look at, for example, on the Rural Health Task Force, John Olson from the Health Department has a pool of grant funds that he has allocated dollars to bring in people to help us understand. And so I will say that they were so focused on COVID over the last period that there was a little bit of a decline in the collaboration, but that's because we had to step back, just as we had to step back in our regulatory roles on the hospitals and realize that, you know, you have to prioritize what is the most important thing at any given point in time. And so hopefully we're entering that phase where we can all start going back to a more normalized role at trying to better the system. So before I don't get to your question, Jane, on the EB5 thing, I really want to address this because believe me, I stayed up nights thinking about this when I first came over to the board, because if you recall, I chaired the Economic Development Committee, and the whole EB5 thing was just unbelievable what unfolded there. And, you know, I still knock myself out to this day saying, probably should have been asking even tougher questions, but the answers that we were getting were assuring us, and the whole pressure that was on us was trying to figure out ways to create better education systems and create a workforce that was going to handle all these new jobs up in your neck of the woods.
I was thinking more from an organization.
Yeah, no, I get it. And so I'm just trying to get there.
Yeah.
So what's become increasingly clear to me since being at the Green Mountain Care Board is if your regulator isn't in tune with what your state policy is, you're not going to be successful. And in fact, some states, so for example, Rhode Island, when they wanted to increase primary care spend, the way they did that reform was through regulation. And so you can't.
You had to require a certain percentage of healthcare spending is directed to.
And you can't push reform efforts if, for example, a hospital isn't being pushed in their budget process to try to demonstrate moving towards more value-based care and away from fee-for-service, those type of things. And one of the things that we keep hearing from our partners in Washington is one of the reasons why they agreed to a model with the state of Vermont is we had this independent body that could do the regulation and the oversight. And really, when you think about it, they've allowed us to step in their shoes for Medicare in some cases with the Medicare benchmark rate, things like that, and things that, 20 years ago, we were never even thinking about as possible pieces of our reform, Medicare being a piece of that. So when Pennsylvania did they're in the process of doing a model now on rural healthcare, and the feds encouraged them to set up a regulatory body. So I think that your regulatory body has to be integrated into any type of reform effort that you have. And whenever somebody says, don't you fear that you're being a promoter and not a regulator, similar to EB5, I say no. What we're doing is, through our regulation, is we're implementing the laws of the state of Vermont, which were passed by the legislature, signed by the governor. So 113 and other pieces of legislation, that is the law of the state of Vermont. And those are the things that we're pushing in our regulation. We're not promoting. Some people say, are you promoting one care? Well, no, we're not promoting one care. We're promoting the move towards value-based care, towards prevention and treatment, towards, a healthcare system rather than a sick care system. And so I don't think that there necessarily is a conflict, but it took me a long time to get there. So hopefully that answers that.
I think I'm asking the question very straightforward because this is part of what we're hearing. And this is our opportunity to have your insights. Yeah.
Yep.
So that's, but it also, over time, maybe we're operationalizing the board in ways that, isn't the most appropriate, or upon reflection, adds duties and therefore more competition for the resources and the time. So it's a broader question in terms of.
But for the most part, I would encourage you not to create silos.
Well, as I said, our problem is not, is siloed thinking.
Yeah.
Frankly, because everything interrelates to everything else. So, yeah, that is a challenge. So, but I just wanted to put it out there and get your response.
So we also review the Vital budget, and I do want to say something positive about Vital. Through your efforts, you know, allowing for the change in the opt-in, opt-out policy, that has really made some vast improvements. And I have been really impressed with Beth Anderson and her team at Vital. And, you know, they're doing their absolute best to continually improve. And so I just want to give them a positive shout out because they have been working hard.
So historically, there has been a problem with the accuracy of the data and so forth. Could you just give us a read? Are we in a better place today in terms of confidence on the part of the you know, provider community having feeling that the data is good?
I think we're in a better place. We're not in the place that we need to be.
Okay, that's all. I don't need anything more than that. Progress still needed.
Yes.
Okay.
So we talked a little bit about CONs. There's been a huge pent up demand. Everybody put everything on hold during the pandemic. So we have probably the largest amounts of certificate of need filings occurring now than at any time during my tenure there. And one of the things, again, I want to point out is that, yes, you could deny capital improvements, but you have to deny the right capital improvements. And so, for example, we have a couple of hospitals in our states that have very old age of plants. I'll pick on Southwestern Vermont Medical Center. They have, I think they're currently the highest average age days of plant of any of the hospitals in the state of Vermont. So you've got to also at some point want to support them in modernizing things because you want to see efficiencies occurring. And, you know, everything changes over time. So for example, a CON that we approved a few years ago that recently opened in Rutland created an addition to the hospital, but it was able to allow them to bring in orthopedists and ENTs that is sites where they had been renting into the space specifically designed rather than taking an old building and retrofitting it. It was space specifically designed to maximize efficiency and flow for the patient so that, yes, it was a significant capital project, but if you look at the useful life of that building, it's going to pay dividends in the long haul. And those are the type of things that you have to look at. The most recent big budget CON item submittal was the recent submittal of a conceptual CON for a surgery center on Tilly Drive. And so hospital sustainability planning, again, you put that into statute. We're not going to meet the September deadline that you gave us. You gave us the ability to push that back to November 15th if the pandemic slowed things down. The pandemic definitely slowed things down in our ability to have the conversations with hospitals and other providers. So for example, we did analysis using a couple of consultants, Burns and BRG, Berkeley Research Group, that we needed feedback from the hospitals on. And we couldn't get feedback 6 or 7 months ago. It was just, you know, all hands were on deck. Now we can. So we're definitely going to need at least that November 15th. My staff has pushed me to lobby you for a further extension. Susan's smiling because I already told her no, that we weren't going to ask you, but I will throw that out that I hope to meet that November 15th deadline, but I also don't want you to give you a junk product. So we may have to say, can we have another month or two? So again, we're charged with ACO oversight and certification. Probably a lot of you don't know about the fact that we recently were approached by Clover Health that came before us and wanted to us to approve a waiver of them having to do any reporting to us. And their basic main argument was that it was the Medicare population that they're working with. And we denied that complete waiver. One of the reasons for that is that because of our goals that we have with total cost of care and everything, we can't have pockets where we're not seeing what's happening. And so we're working with them, with the healthcare advocate, and trying to come up with a reduced, least restrictive type of reporting environment that they could have. But the basic premise, and they have 20 providers, but those 20 providers are all affiliated with one practice. The providers love it because each time they click on Clover Health's computer system, they get $45. So it's great for the docs, but there's no requirement for the doctors to do anything differently with better coordinating care and things like that. Hopefully with the information, that would be the end result, but there's nothing that would guarantee that. And here's another, with the good news comes the bad. Yes, they're providing these providers with a better information system, but the way that Clover Health makes money, and Clover Health is a meme stock.
You tell me Clover Health. I don't.
idea who you're talking about.
I thought maybe I was the only one.
No, I just think.
It's a national company that it actually made a lot of national news recently for a number of reasons. One, because it became a meme stock where the GameStop people and the AMC, those publicly traded Reddit crowd were driving the price of that the stock shares up. But it also has gotten a lot of negative publicity because they've had some charges of improper behavior with their SEC filings and things like that. So
How do you spell it?
CLOVER.
Just like the flower, clover.
Okay. Sorry.
My enunciation probably needs to be improved. I did see that Vermonters aren't losing their accent, so that's a good thing.
Yeah.
Yep. So again, Health Connect, we talked already about the databases. How we're always trying to continue to improve those. We talked about the advisory groups already. Data Governance Council, anybody who wishes to use the data has to go before the Data Governance Council, which Susan is the chair of, and basically show that they're using it for the right reasons. We want to encourage research and other use of the data for people to make better decisions. We just don't want it to be used for the wrong purposes.
So may I ask a question
Yeah,
about that?
please, yeah.
All right, so one of the things that we're struggling with, and we actually put in some language in a bill for our joint fiscal office to be able to retain independent consultative services. So if, for example, the legislature really wanted to hone in on some of the data that you're talking about, would that be subject to the confidentiality review?
Susan, you want to answer that one?
Sure, I would, Susan Barrett, Executive Director of the Green Mountain Care Board. If you wanted access to the VCure's database, you would have to go through like any other state agency, a DUA process. So we have all of the information on our website, and I'd be happy to work with Nolan or others to review that information.
Okay. I was just wondering because I'm just trying to link what Donna was telling us in terms of, in order to make decisions around, do we need to make any modifications, et cetera, we really need to fully understand what we have for data analysis. And I must say, there's mountains of data. And so what could be very helpful to us is really someone taking a very hard look at all the information and distilling it in a way that could help
And I think that would be
form
very easy to see
acti-
for data governance.
And so,
Policy research.
so that's my question is if we felt that we wanted to really create a deeper legislative understanding, and I made a note here, because here the stewards of healthcare data, producers of research and analyses. Well, if we actually could have a little horsepower here, it's to help policymakers. Well, we're policymakers, and yet, we have no capacity other than what you give us.
Yeah, would improve the
My point earlier.
Yeah,
we
that resonated.
do not
That's-
have the resources.
So
to do the
I'm
work
just
that we're required
saying,
to
if we really wanted to look more deeply in terms of what actions or, policy that might come from that, or modifications to the regulatory structure. All right, you've answered my question on that.
So
Thank you.
the next one is the annual expenditure analysis. It's a very thick document that's done every year. Lori Perry from our staff has been doing that since before even the Green Mountain Care Board, when she worked at Bishka. And, it's very helpful. We're always in a lag. So right now we have 2019, but that just came out a few months ago, really. And so here we are in 21, and we're looking at finalized information for 2019. We don't even have finalized information for 20. So that is frustrating. And of course, 20 is going to be an anomaly anyways because of what happened during the pandemic. But that expenditure analysis in 2018, we actually had some very, very positive news where overall spending on healthcare only went up 1.8%. And as a percentage of GDP, it went down from over 19 to 18.5%. The bad news is that 19, it ticked a little bit in the other direction where overall spending grew at 4.1%, and we went back up to 19. So at least we're not going on that same trajectory of even higher, but.
So just in light of the earlier question and comment in terms of long-term care and how that falls into healthcare expenditure, can you just clarify what the relationship is of the annual expenditure analysis and the relationship to issues of long-term care?
So the expenditure analysis does have measurements, but I would say if you wanted to look at a piece where we really don't have a lot of expertise, is long-term care, because we're not regulating long-term care at all. We're not even doing the CONs for them, which was a good thing because we didn't have the expertise to do the CONs either. But I would say, as a Vermonter, not as the chair of the Green Mountain Care Board, my biggest fears are what's happening in nursing homes. And I have personal experience because I have a parent. And so we see it. You think that hospitals can't get nurses and other staff members. Hospitals are spending $145 an hour for travelers, and they could have 3 Vermonters working those positions. But then you look at nursing homes, and they're having such turnover. I spoke to an operator of one down my way a few weeks ago, and they had just made an arrangement to bring 5 people in from Jamaica for caregivers because they just can never meet their staffing levels that they want because people are leaving. They get somebody trained, they're doing a good job, and then they get hired away by a hospital. Just like what we heard from the DAs,
What happens?
where help was getting hired away by the schools.
Well, and it's
Yeah.
anyway, that's a whole.
Yeah.
Right. So,
Already
but
flagged that.
but specifically in terms of the annual expenditure analysis, is long-term care included?
Yeah, but it's not as in-depth as what I would say would give you the information that you would need to make great decisions.
Okay, but it's within the boundary of healthcare expenditure.
Don't know if it's included in that definition. Susan, do you know?
Because I frankly don't know. I mean, I have to honestly say, I've been sitting here thinking I'm embarrassed to say I couldn't tell you whether it's included. I'm guessing it's not. Because it's generally outside the boundaries of
I'll just
what
email
we're
it.
generally talking about.
It would be some data because it's been incorporated into the choices for care as in part of the waiver. But then there's the 30% private pay that wouldn't be captured there.
I'd be
So,
interested just to
yeah.
understand it more.
I will say it's frustrating because it even filters over. So for example, last year, one of the arguments that Porter Hospital was making to try to get more is how much money they were losing at Helen Porter. And that was one of their justifications they were trying to get for higher charges. And should a small percentage of the population that's using commercial insurance be paying for the fact that they're not getting reimbursed enough in Medicaid? And here's the other thing that I'll tell you is that when you take a look at what they're getting reimbursed, they're at the upper end. I say there's 3 buckets of reimbursements for nursing homes when it comes to Medicaid. You've got the Veterans Home, which is at, I think, a little over $400 a day for reimbursement. Okay, they're at the very high end. And then you've got the power of the hospitals and their lobbying arms and everything. So 25% less reimbursement than the Veterans Home, which the state oversees, are Woodridge and Helen Porter. So they're around $300. All the other nursing homes are in the hundreds. And we're asking them to take care of our most vulnerable people,
sickest.
and they have no resources. So that's just my soapbox for the plight of the nursing homes.
Mental
I
health
just think,
probably.
we really need to focus on this at some point. Because also, but we just did something with taxes. I'm looking at you, and a couple of years ago, those what I call continuing move in when you feel okay, and then when you don't, and by taxing, we did a nice little tax thing saying that they're part of their costs they can identify as a medical expense.
And we're doing great things in Vermont, keeping people out of nursing homes, but you can't keep everybody out of a nursing home. My parent is an example of that. When it comes to dementia, we had 24/7 in-home care, and it still wasn't really doing the job. So we had to go to a nursing home. And, that's not to say that SASH and other programs weren't trying to help, but it doesn't work in all cases. And we're seeing as people live longer, more people are having dementia-related issues. And it's just one of those things that is going to have to be dealt with.
So I'm thinking about time.
Just
We're
look
also
at
going to
that.
have to,
Over
sorry.
and maybe give you a
Can I make a
chance to kind
comment?
of, yes, please, Senator Lyons.
just really quickly, because it does raise the whole issue of residential care facilities and the full spectrum all the way up to the nursing homes where there is full medical care, and how to deal with each of those different levels and the licensure and registration of some of those. It does get more complicated than just saying long-term care facility.
Yeah.
Yeah.
And I will say that we have some great state employees in Dale and the licensing division, and they're doing incredible work, but it's the fact that I don't know how you're successful operating a nursing home in today's environment.
Yeah.
There's just too many pressures on you.
So, Chair Mullen, I wasn't trying to cut us off. I wanted to give you a few moments to wrap up and make sure that you had an opportunity to.
The big thing is you have the slides, and I can come back at any time. So, I really want to open it up to broader questions from you. So I'm just going to stop there for broader questions because we are past time.
Yeah. Thank you. Thank you very much. So
we could probably have a much longer conversation, and I'm not seeing a need for us to be doing that right now. This committee needs to have a conversation about what its next steps are. So I'll say thank you very much. This is very helpful. We have the slides deck and we'll review it and probably see you again.
And we'll get those answers to those questions back to you. And, again, we're available at any time, so.
We're adjourning them at this point?
No, well, I'm not letting us adjourn. I'm letting Chair.
No, I was just going to say, if Rachel and Donna are still listening, I think if we're just going into where we go from here, I was just going to thank them.
Yes, well, please go ahead and thank them. It really was very helpful having Ms. Block and Ms. Kinsler.
And Rachel, for those of us who have been around a very long time, of course, has a Vermont connection back in the Dean administration. So she has followed healthcare in Vermont for a lot of years, huh, Rachel?
Well, it's our pleasure to help the committee, and if the Millbank Memorial Fund can do anything else, as you know, please let us know.
And,
Don't worry.
Thank
We'll
you
be
very
in
much
touch.
for.
Thank you.
And we
for
will
having
be
me
in
today.
touch. So you've helped us formulate, I think, a path forward. And so I think that's the question that we need to have among ourselves. And I don't know if folks need some time to think about it, but I'm thinking about what our role is versus the role of other entities, and wanting to be clear about what we're going to be doing and what other groups are doing. And
Well, we have the task force, and Representative Lippert and Senator Lyons are in charge of those 6 areas that were specified. So we fortunately have the ability to make that coordination, because we certainly don't want to duplicate efforts and keep any further meetings of this committee on issues that are separate and apart from those, although they're connections.
Senator Cummings has been trying to jump in. I see
sure.
that.
Well, it was the comment I wanted to make before is we have the obligation to make sure we have the correct regulatory system. But then there's our system, which in the long run is set up to be very inefficient. The legislature turns over every 2 years. So we do something now, and then next year, and we all change committees. So next year you get new members and there is a new cause du jour. And Senator Lyons mentioned detailing. Well, actually, I remember doing that many, many years ago, and it was called anti-detailing. But I have no idea if it's still happening, what it's accomplished. I know we had trouble with coffee at medical conventions and nasty anti-Vermont signs. But I don't know. And is that, and I think it gets to the how, and maybe it's just orientation. When you start a new year, it is such a complicated system. How do you bring everybody up to speed on this is what we did last year, this is the status? Because when you walk in the door, you've got 3 other crises. And I think that's something that for us, we need to own what we've done in the past. And if you come in here new or you're off the committee, as I was off finance for I think 4 or 5 years, just catching up on what happened while you were gone is
It's a challenge.
it's a challenge.
Yeah. Well, and I think we're trying to give ourselves a jump start with
Yes.
this summer work. Bill, you wanted to, I'm
Well, I-
sorry, I'm going to first names.
So
Yeah.
I want to come back to what Senator Kitchell and I think from different angles, or maybe from similar angles, actually, I'm saying in terms of and what I think you're saying, Senator Cummings, in many ways, I think one of the things that we could do most effectively, apart from specific content issues, is our own analysis of our ability as the institution of the legislature to actually put our arms around the issues of healthcare and what it is we need to have in terms of resource to do that. And it touches on a number of the issues which, Senator Cummings, some of which are inherent in our institution, which is turnover and, but it's a tremendously complex area. And some of the members of this committee have had the history and good fortune of a longer tenure, certainly longer than mine, as I focused it elsewhere prior to coming into healthcare. But in my view, we struggle with how to come to terms with the big questions that get put to us, both by external stakeholders as well as that are generated internally. So do we have the right regulatory structure and authority? And I think we should come to grips with that. But we can't, in my view, I don't think we can come to a conclusion about that without having our own ability to say, how would we come to that conclusion? What are the resources that we can bring to bear? Is it through staffing? Is it through contractual work, et cetera? And I think that alone, apart from specifics of any particular issue, would be a valuable contribution if this committee could come to grips with our institution's ability to wrestle with healthcare in terms of the resources.
So I see your hand, Senator Lyons, just a second, but I think what Ms. Kinsler suggested to us, if you look at her it is essentially the last page of her presentation, a series of next steps that this committee could consider. You've raised the question, Lippert, of do we have the right regulatory regime? And I think
that's been on the table.
It has been on the table. It's out there. It's hanging out there. And I think one of the things that we have heard loud and clear from Ms. Kinsler's presentation is you need to do some analysis of where you are before you can answer that question.
And she might be available
to help us accomplish that. And so we have before us a suggestion on what some next steps for this group could be. And we need to coordinate it again with the healthcare task force so that we're not competing or at odds with each other. So I just want to refer us to that, but Senator Lyons.
and have you met?
Yeah, thank you. That's where I was going, and looking at what our goals are. And currently, and for the task force, we're asked to consider Act 48 and previous reports that have come to us as a result of legislation. But I don't think that actually, because a task force has that as kind of its a guiding principle. I think that what would be helpful for us is to look at where we are with respect to an Act 48, a single payer. Is that still the goal that is in place, or what other legislation has come forward that would change those goals, and in what way, how?
You're talking about the task force now. I just want to be clear.
Yeah.
No, I'm saying I've moved from the task force to HROC. And I'm thinking that HROC should be looking at and bringing Chair Mullen back to look at the all-payer model and the ACO and what's happening there, because there are some policy implications as well as the work that we've done on Blueprint that would have changed in some ways, modified the goals that we had through, or maybe even clarified those goals. But I think that last slide that you referenced from Donna Kinzer is a very critical slide. Our regulatory entity, is that the entity we need? And then how do we analyze that? And you're absolutely right. We don't have the legislative capacity to do that analysis. But it does require some consistency and longevity on the part of legislators in order to actually understand what's happening. So I guess my thinking would be that we should perhaps ask Donna Kinzer for some further help in looking at where we are in our goals, but then also asking Green Mountain Care Board to come in and clarify where we are with the waiver and all payer model. So
we had actually hoped to have a conversation about the all payer model. If you look at Rep. Kevin Mullen's slide deck, you saw that was the second half of it. We just didn't get there. But back to what our next steps were, I certainly am attracted to the notion of getting additional assistance on looking at the data as it's associated with where we are today. And I think that is what Ms. Kinzer, I keep mispronouncing her name.
You want to add an L?
Yeah. Interrogating that question before we can say, do we have the right regulatory model or not? We need to ask ourselves where we are today. So
I think that's really what she was advising us, is to say, you can't say that we have the right, or we need to model, or we need to modify it until we get that, the benefit of the data and an analysis of that. And that probably takes some work. And I think we're all recognizing, and I think the Joint Fiscal Office was recognizing it when they came and said, we have some money in our budget, we just want to have the sanction or the recognition, then we need some additional horsepower.
When did this happen? I mean,
It happened in H315. It happened, and the language is in H315, which was that earlier budget bill to give them the authority. They haven't exercised it, so everybody, but they felt that they were anticipating this additional work. And in some ways, I'm thinking about, for IT projects, for example, we had Dan Smith, who advised us, would look at,
and he was very helpful.
and he was very helpful to
Where I
us.
sat it.
Yes, and I think we were feeling it was helpful and saying, yes, this is the right investment, or this is the right, or this is where your problems are. So,
And that's exactly the kind of thing I've been thinking about, and I've been trying to articulate that we need, we have terrific staff, but we don't have the capacity to do the kind of analysis that, or the research and analysis that can help inform us, particularly given, and I think we need to recognize that the nature, we're sitting here as a committee, it's a summer study, if you will, but we're actually an ongoing committee that is now meeting again. But nevertheless, we operate as citizen legislators. And we are a citizen legislature. We are not full-time. We as legislators ourselves are not, our role is not structured in a way that we can participate at the same level as the external entities who are full-time doing this. And so we're dependent on, we're more dependent on the resource of our own institution, of the legislature's ability to assist us.
And so on some level, that's joint fiscal and legislative council as contrasted to the Green Mountain Care
Yeah,
Board.
exactly. Well, that's what I'm saying. Because we end up being dependent on asking.
On the administration.
And asking the administration or the independent entity of the Green Mountain Care Board to give us the information to then use to quote, evaluate something about them. And that's the dilemma.
Yeah, I want to go back to something that Representative Pugh said about if there's no capacity, there's no data. And I've had experience with the Vermont healthcare system in this past year at all its levels, and I've seen some good in some areas I was not. And it tends to be at the bottom level. We talk about a medical home. Well, what if your provider turns over every year? I had one on my prescription bottle that said that was my primary care provider. I never met the person. We were talking about Vital, I don't ever remember anyone asking me if I wanted my medical records on Vital. So I asked my primary care provider, and she said, well, that would be with the receptionist. Talk to her. And then they were at a meeting and no one was there to talk to. But I did get some good ideas about they are so bogged down in, and everything now is on a computer. And I'm not sure whose computers are talking to whose computers and what information is being transmitted and what isn't and how. And that initial experience when you walk through the door to something that if it is confusing to me, who did some experience here, what does it do for the average person who's not sure how they're going to pay for any of it? And I think that would be someplace who actually checks. It's like who actually checks and is detailing happening in or anti-detailing or whatever it is.
I think, Anne, your comment about that it touched, I can't remember who made the comment, that we implement things, but we don't have the kind of follow-up so that we know. For example, we got the blueprint reports and that was all investing in the front end to avoid the back end and so forth. But over time, we're very weak in that ability to determine, did we get the outcome we wanted with this policy or this expenditure? And I think that's what we're struggling with. We put these things in place and we're sitting here sort of ad hoc getting information, but kind of in a fog in terms of what we need to do and where we are.
So there are many questions that we could be asking ourselves, and Senator Cummings just raised an interesting, a big area.
Can I, with all due respect, Senator Cummings, can I say that what you've just identified is about that big of the healthcare areas that so I mean, in fairness, it's like the list of things. When I think about having to orient brand new committee members to the healthcare world, which we've had to do regularly, there is so much to think about covering. And so I don't say that to dismiss your question.
No, I think
Just to say that there's so much to understand and
So
somewhere in our
But
regulatory
listen,
process.
I think the question that Senator Cummings is asking, they're good questions, and they are similar to questions that she asked in our committee meeting. But the question is, how do you close those gaps? And I think those are examples of some of the gaps that were brought up earlier around both the regulatory entities, but also patient access and cost, because every time you have a gap, it's an increase in cost and time and effort and ultimately money. So I think for me, the question that I'd like to have answered in our discussion is, what is this HROC going to be looking at in the near future that will not be in
That's what I was trying
conflict
to-
with
yeah.
the task force? Because we can pick any aspect of healthcare. It is complex, and it does all link together. So just the question I think raised earlier is, how do we evaluate the board itself without having the board do its own evaluation? What are the goals that we consistently have now? And then it just flew out of my mind, but the all payer and waiver process, what's happening there? Because I think that leads us into a discussion, a systemic discussion. What's the system look like and how can it be improved? So it does link in with long-term care. Where does it link in with long-term care, substance use disorder, mental health? So I think those are
Everything connects to everything, so we got the whole
Everything, yeah,
world
right,
here. I think
yeah.
this page is very helpful
Yeah.
to
So
give the
just-
framework.
Just to draw us back again to Ms. Kinsler's presentation. Kinzer, I'm sorry. It's permanent now. It's the second to last page, and she's framed up an approach. And I think we need to look at that and see if that makes sense to us.
This committee.
For this committee. Again, the task force has different directive and different orientation, but this is the question for us. And I'm coming back to wanting to be very data-driven, based on information, and wanting to understand what the data is telling us before we say we should go in this or that direction in terms of, looking at the board or other systems of regulation, et cetera. Let's understand where we are now. I am a wee bit concerned that if we don't narrow it in to particular data sets or particular areas of interrogation, that we're looking at too much. And I don't know if in fact that's true. I don't know if it's been suggested that long-term care and mental health are two particularly ripe areas for looking at and understanding. So should we focus down on that? And workforce is going to cross everything
I think we've got to pare it down and sort of do things in chunks. Otherwise it becomes too big and overwhelming. So I think, and particularly hearing Representative Ansell's interest and comments is really taking advantage and fully understanding where we are right now and answering these questions. So I think for a first step of work and the role of this committee, this lends itself, because it does obviously get into the fiscal areas and want to have the subject committee areas respected, which I think the task force was designed to do. So I think maybe we should have some conversations with the head of joint fiscal in terms of what we might have for resources to help us, give us some horsepower to do that data analysis, that independent examination of where we are right now. And
I think in the course of having that conversation or having conversations, we're going to require ourselves to be more specific about what, how to use that resource. To answer these questions are quite broad.
They're very, very broad. That's
But
my only concern. Yeah.
but maybe that we can get them narrowed down. The first step is helping us better understand what questions we should be asking. It was like, well, God, it's so enormous. What should be our first area of inquiry?
Well, I guess,
I'm
that's
beginning to,
the question about the cost of the Green Mountain Care Board itself. Are we investing too much in that regulatory entity? And how do we answer
I'm
that?
not sure
That's
we're-
a subsequent question.
Yeah, that's the next, a next step is question.
But it's there.
Yes, it's very much there, but I think we need some basic data, some basic foundational work.
I guess what you're asking is the return on the investment in terms of the regulatory and the outcomes relative to the cost and the way it's structured. So maybe it does
Yeah,
emerge.
And
to some
I
extent.
think also, have we piled on? I mean, we've asked the board to do a significant amount of work. And so recently asking for hospital sustainability planning, which we understand is critical for survival of hospitals and also cost containment. But are there other things that we've asked the board to do that are now less important or that should be accomplished in other ways? So just, I don't know. I don't know the answer to that.
So many questions.
Yeah,
Few answers.
yeah.
That's it.
But we need to begin somewhere.
And I have to
so-
leave at noon.
Yeah,
because I'm-
so there's a proposal on the table. I believe there's a proposal on the table to look at essentially, understanding what it would take to be answering the questions that are being suggested to us on the handout that I keep referring to. And
Age.
Next to the
Next
last.
that age,
Just
because the
before the-
last is
yeah.
the bio.
Yeah,
Okay.
Right.
That's what I thought.
And I think clearly that if we enter into a relationship with someone, it'll probably end up being narrowed down more from, these are very, very broad, but it's a place to begin. Is that, so shall we begin there? That's the question.
First thing you can do is define synthesis of quantitative and qualitative analytics.
I know, right there. Wow.
That could take a whole session.
And we could,
Well, I think what could take a whole session, and this is what we're wrestling with, is what are the goals?
What are the goals?
Yeah.
So what goal are we talking about? The goal of this committee, the goal of the cost containment and regulatory structure,
right.
or the goals that we have scattered in the words of, or taking off from what Senator Cummings said, that we put in every piece of legislation around some aspect of healthcare, we have some goal that it's going to do. And so I don't know even what goal, I'll be honest, I love the structure and I do hope someone comes back and says, what are the goals? Because I don't know what we're talking
I wrote
about.
down.
We need a mission.
What are the-
Representative
okay,
Pugh,
I'm not the only one who's a bit.
Yeah.
Representative Pugh, the
So-
question you're asking is, who are we? We are the Health Reform.
Oh my gosh, oh, this is
So-
getting
so
so
where
existential.
our health
That's an Emily
reform,
Dickinson poem.
the healthcare reform right now is the waiver and the all-payer model. So is that where we start? Don't know.
I think we were suggesting, and I think there's a desire to really look at, go back to the mission and the goal of our regulatory structure and take the data and look at what an analysis and help us, because that is the mechanism by which we are looking at the whole issue around cost containment, healthcare outcomes, quality, et cetera. So I think that's a good place to start, because this is enormous. I think Representative Lippert had his arms wide out. I think we could all hold hands and expand it even more. And also the extent to which, we have the additional resources available to us right now to help us, give us some depth in this work. And all I can think of is somewhat analogous to what Dan Smith is able to do on those big IT projects.
Let us take this conversation and engage JFO in helping to refine that and come up with a statement of where we're going to go that can then become of a contract with whomever to accomplish what we're agreeing to, and we can share that with this group.
Or we can communicate
Yeah.
amongst ourselves
Yeah,
as we. try
to accomplish that, yeah.
I mean, I know JFO has a plan, but can we include legislative council in the we when you talk about when we engage with JFO?
Oh, absolutely.
I think, yeah, Jen has frequent, and I guess we assume that. Thank you for
I
bringing
just want, perhaps it's obvious. I
No,
just want to
no,
state
no, I
that.
think it's sometimes things you assume turn out not to be true, Representative Pugh,
Yeah,
as we well know.
so I don't think that,
And the very fact that Jen is here this morning
Yeah,
is an
is-
indication of that.
thanks for spending the morning with us.
Yeah.
And ditto, Nolan. So I don't think that we can set a time, for our next meeting. So we'll put together a proposal and continue having a conversation about what the proposal should be, share it out among ourselves, and then figure out next steps from there. Okay, so agreement,
Yeah, I
that
think
kind of a direction and a purpose
Yeah, we
here.
need to do a little homework.
Yeah, a little more work.